How about patients with diabetes? The literature is kind of schizophrenic on this end. On one hand, my dear colleague Tom Oates, who's my boss down at the University of Maryland, has shown in reviews that appropriate accommodations should be made, according to his words, for implant integration. If you go back to the studies at San Antonio, Texas, by Scott Dowell and others, patients with poorly controlled diabetes can heal and can achieve osseointegration, but it may take longer. And the problem is you talk to a lot of diabetic patients and they always tell you, oh yes, I'm well controlled. And then you ask them what's their A1C values, and then they say they're 8.1. 8.1? That's not well controlled. So you're constantly fighting this battle of how long will it take for them to heal, and Osstell is a great way to determine, beyond just glycemic control, where they're at with their bone healing. With respect to developing peri-implantitis, the World Classification Workshop recently determined that diabetes is inconclusive for being a prerequisite to developing peri-implantitis. So we have this battling situation. So I like to use the Osstell for patients with a compromise in terms of their medical status, and Dr. Kuchler is going to go into that in much better detail than I can possibly give you in about 7.5 minutes here. So this is a patient who is a diabetic, well controlled, 5.9 in his glycemic control with his hemoglobin A1C. The tooth, which is the lower right first premolar, is deemed hopeless due to historic caries and failed endodontics. So it was extracted, and the site was immediately implanted. Great insertion torque and excellent stability. ISQ of 70 in the buccal lingual direction, 69 mesiodistally. So a healing abutment was applied, and I used a combination here of a bovine-derived xenograft mixed with collagen, and that was hydrated with platelet-derived growth factor, recombinant platelet-derived growth factor, and I have to profess this is an off-label use, but nonetheless, I could give you good evidence as to why I do that. And on top of that, I happen to use a collagen membrane. Site was sutured. You can see how it looks at 10 days post-op. The soft tissue wound healing is excellent in this patient. And at 30 days, it is still consistent with someone who would seem to be fairly well controlled in their glycemic observations. At 12 weeks, I decided to get an RFA reading. If you look, we're far better than where we began. So some people would just capriciously say all diabetics need to heal for 6 months. Not this individual. This individual might have been good at 8 weeks. I arbitrarily decided to look at 12. I felt that the soft tissue was mature enough and that if we wished to proceed to completion, we could, which is exactly what we did. And this was the patient at 5 months, though he was completed somewhere at around 4 months.